You got the blood tests, you brought the results to your doctor, the number came back fine. Fasting insulin, normal. Blood sugar, normal. A1C, normal. And yet, the fat around your midsection has not moved, not even a little. If that sounds familiar, you are not imagining it, and your body is not broken. But here is what most standard lab panels quietly miss, and what nobody explains to you sitting in that waiting room. A normal reading on a fasting insulin test does not mean your insulin is working properly for fat loss. There is a zone that sits between textbook normal and clinical insulin resistance, a zone where your metabolism is already struggling, your body is already packing fat into your deep abdominal tissue, and none of the standard markers are catching it yet. Research published in Diabetes Care has documented this zone. Scientists call it subclinical hyperinsulinemia. Subclinical simply means below the threshold where most clinicians intervene. But subclinical does not mean harmless. It means your insulin is chronically elevated just enough to quietly switch off the cellular machinery your body depends on to move visceral fat. This matters especially if you are over 40. Insulin sensitivity naturally declines with age, and even modest, persistent elevations in baseline insulin start having disproportionate effects on where fat gets deposited. The deep abdominal layer, the tissue packed around your organs, is the first to fill. Here's what this video covers. What subclinical hyperinsulinemia actually is at the cellular level, exactly how it switches off your body's fat mobilization signaling, why the standard fasting insulin test frequently misses it, what the research suggests is a more informative marker for visceral fat accumulation, and what that means practically, what you can do about it. Stay with me because the mechanism I'm about to explain, the one involving a specific energy-sensing enzyme inside your cells, is the part most fat loss content never gets to. And once you understand it, you'll see the whole picture differently. Think of insulin like the volume dial on a radio. A little insulin is necessary. It is the signal your cells use to pull glucose out of your bloodstream after a meal. But when that dial never fully turns down, when there is always a low, persistent hum of insulin in your system, even hours after eating, your cells start to tune it out. That tuning out process is the early stage of insulin resistance. But here's the part that gets missed. Most fasting insulin reference ranges were built to identify clinical insulin resistance, the kind that shows up alongside elevated blood sugar and, eventually, type 2 diabetes. The upper boundary of the so-called normal range typically sits around 25 microunits per milliliter. But research published in the Journal of Clinical Endocrinology and Metabolism found that fasting insulin above 10 to 12 microunits per milliliter is already associated with meaningfully impaired metabolic signaling, even when blood glucose remains completely normal. This is the subclinical zone. Your doctor sees the result, it falls inside the reference range, and tells you everything looks fine. But at the cellular level, something important is already being suppressed. That something is an enzyme called AMPK, AMP-activated protein kinase. Think of AMPK as your cell's fuel gauge. When your cells are running low on energy, AMPK fires. It signals the body to break down stored fat and burn it. When AMPK is active, fat mobilization happens. When AMPK is suppressed, that signal goes quiet and your body defaults to storing. Research published in Cell Metabolism has documented that elevated insulin directly suppresses AMPK activity. Even modest chronic elevations in baseline insulin, the kind that sits comfortably inside the normal reference range, keep AMPK in a switched-off state. Your cell's fuel gauge is stuck. The signal to mobilize visceral fat does not fire. With AMPK suppressed, the body defaults to energy storage, and visceral fat, the deep abdominal layer wrapping your liver, intestines, and other organs, is disproportionately affected. Here's why. Visceral fat cells carry a higher density of insulin receptors compared to subcutaneous fat, the fat sitting just beneath the skin. That means visceral tissue is more sensitive to insulin's fat storage signal. When insulin stays elevated, even at low levels, the visceral depot fills preferentially. You might be eating the same amount as a friend and gaining fat in a completely different place, for a reason that has nothing to do with willpower or discipline. There's a second pathway compounding this. Research published in the American Journal of Clinical Nutrition documented a process called hepatic de novo lipogenesis, the liver's ability to convert excess carbohydrates directly into fat. Insulin is the primary driver of that conversion. Elevated baseline insulin keeps the liver in a fat-producing state. The fat the liver produces does not stay there. It gets packaged into particles called VLDL and shipped into the bloodstream, where it ends up deposited in visceral tissue. So you have two mechanisms running at the same time. AMPK suppression is reducing your body's ability to mobilize stored fat, and elevated insulin is driving the liver to produce new fat and send it straight to your visceral depot. The scale might not show dramatic changes, but what is happening to your body composition and to your metabolic risk is significant. Before we get to what the research suggests you should actually be measuring, there's one more layer here. It involves why the standard test is missing this, and it's not because the test is wrong, it's because it's measuring the wrong thing. Most physicians who do assess insulin resistance use a calculation called HOMA-IR, the Homeostatic Model Assessment of Insulin Resistance. It combines your fasting insulin and your fasting glucose in a simple formula. A score below 1.5 is generally considered insulin sensitive. Above 2.0 suggests early resistance. The problem is that HOMA-IR, like fasting insulin alone, was designed to detect significant insulin resistance, not the subclinical dysfunction that precedes it. Research published in the journal Obesity compared HOMA-IR scores against direct imaging measurements of visceral fat using CT scans and MRI. The data showed that meaningful visceral fat accumulation was already present in people whose HOMA-IR scores fell inside the healthy range. In real terms, that means someone can have a HOMA-IR of 1.4, technically normal, and already be carrying a visceral fat burden that raises metabolic risk. The test is not inaccurate, it was just never designed to catch what is happening at this earlier stage. A separate body of research has examined what actually predicts visceral fat accumulation with more sensitivity. Findings published in Diabetologia showed that the ratio of fasting triglycerides to HDL cholesterol, the TG over HDL ratio, using milligrams per deciliter units, correlated more strongly with visceral fat and insulin-driven fat storage than fasting insulin alone. A TG over HDL ratio above 2.0 turned up consistently across multiple research cohorts as a marker of elevated insulin-mediated fat storage, even in people whose fasting insulin looked completely fine. This is not a replacement for your doctor's assessment, but it is a piece of data that the research suggests is worth asking for alongside the standard panel, because it captures something about your metabolic state that a fasting insulin number on its own frequently misses. Understanding this mechanism points towards specific approaches. The goal is not simply to eat less. It is to reduce the cumulative insulin load your body is managing across the day, restore AMPK sensitivity, and give your visceral fat cells the signal they have been waiting for. Research from controlled trials published in Diabetes Care and Cell Metabolism has identified 3 consistent patterns among people who successfully reduce visceral fat and shift their metabolic signaling. The first is reducing the frequency and duration of insulin spikes across the day, not just their size. Every time you eat, your body produces an insulin response. When meals are frequent and carbohydrate loads are spread throughout the day without a meaningful gap, baseline insulin never drops far enough to allow AMPK to reset. Research on time-restricted eating, published in Cell Metabolism, found that compressing eating into an 8 to 10-hour window was associated with reductions in fasting insulin and improvements in AMPK-related signaling markers, independent of total calorie intake. The length of the daily fasted window appears to matter for giving insulin time to fall and AMPK time to reactivate. The second is the glycemic quality of your carbohydrates, specifically how fast they push insulin up. Research published in the American Journal of Clinical Nutrition has shown across multiple dietary intervention studies that lower glycemic carbohydrate sources produce slower, smaller insulin responses. Replacing refined carbohydrates with high-fiber, lower glycemic alternatives is one of the most consistently replicated strategies for reducing the total insulin burden your cells face each day. Over time, this is associated with lower fasting insulin levels and improved AMPK activity. The third is resistance training and its effect on AMPK through a completely separate pathway. Research published in the Journal of Applied Physiology showed that resistance exercise activates AMPK in skeletal muscle through changes in the AMP to ATP ratio, independent of insulin. That means even when subclinical hyperinsulinemia is suppressing AMPK in fat tissue, exercise-induced AMPK activation in muscle can partially counteract that suppression and improve the body's ability to burn fat for fuel. The data from exercise physiology research suggest at least 2 sessions per week produces meaningful AMPK-related metabolic effects. None of these approaches work around the need for an energy deficit. A caloric deficit remains the foundation of fat loss, but the research makes a strong case that for people in the subclinical zone, where insulin is elevated enough to suppress fat mobilization but not elevated enough to show up on a standard test, addressing the insulin load may explain why 2 people running the same caloric deficit see very different rates of visceral fat reduction. You are not doing something wrong. Your body is responding to a signal that is not showing up on the panel. Here is where this leaves you. A normal fasting insulin test does not mean your insulin is behaving normally for visceral fat mobilization. The subclinical zone is real. It is well documented in peer-reviewed research, and it operates below the threshold where standard lab panels sound an alarm. If your results look fine, but the fat around your midsection is not changing, the mechanism described in this video may be exactly what is happening. This is not a reason to panic. Your body is not failing. It is responding exactly as the biology predicts, to a persistent signal that most clinical tests are not sensitive enough to pick up. Once you understand what that signal is and where it comes from, you now have real tools to work with. The 3 approaches covered here, compressing your eating window, improving glycemic quality, and building resistance training into your week, are not hacks. They are targeted responses to a specific mechanism that the research has documented clearly. They work by addressing the upstream driver, not just managing symptoms. If this gave you a clearer picture of what is actually happening in your metabolism, hit the like button. It tells me this kind of mechanistic content is worth going deeper on. Drop a comment below. Have you ever had a normal insulin result while still struggling with visceral fat? Tell me what your experience looked like. I read every one. Subscribe if you want more evidence-based metabolic content built for people over 40, content that treats you as someone capable of understanding the real science, not a watered-down version of it. And if you know someone who has been told their labs look fine, but their body is telling them a different story, share this video with them. Your metabolism is not a mystery. It is a mechanism, and mechanisms can be understood and worked with.